Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everyone. I am Dr. Sidra Lodi and I am currently working as Assistant Professor Internal Medicine at King Edward Medical University and also as Consultant Endocrinologist. I welcome you all to today's session of the Hypertension Course 2021. Today's activity shall consist of two talks. The first one shall be by Professor Alta Shute. She will be talking about isolated systolic hypertension and its relevance with the 2020 ISH guidelines. And the second talk shall be by Professor Azazmand Ahmed Saab, who shall be talking about the renal aspects of secondary hypertension. So to formally begin, I shall invite our first speaker, Professor Alta Shute. She is a professor and principal lead of the Cardiac, Vascular and Metabolic Medicine team at the University of New South Wales, Sydney, Australia, and George Institute of Global Health. She is also extraordinary professor at the Northwest University, South Africa. She has over 350 publications in the field of hypertension and cardiovascular disease and is involved in numerous international consortia, including Global Burden of Disease Study, and is an invited author of the Lancet Commission of Hypertension. She is the past president of Southern African Hypertension Society and immediate past president of International Society of Hypertension. Professor Alta Shute, please.
Thank you very much. Shall I just share my screen?
Please. Yes, please.
I trust you can see that?
Yes.
We do.
So do I understand correctly the questionnaires will now be run?
Yes, we would request you to pause for a moment while we have our pre-poll questions.
Excellent. Thank you very much, everyone, for completing the poll. Let me then start with my presentation. Now, first of all, I would like to thank the organizers for the invitation. I'm really delighted to be part of this whole program on increasing knowledge on hypertension management. It's a major cause of death, so a great initiative. So congratulations for that. My presentation is focused, as you've seen also in the poll, on isolated systolic hypertension. And as you may or may not be aware, the International Society of Hypertension released in 2020 the new ISH guidelines. I really recommend that if you're interested to have a quick look at those guidelines. They are very short, only about 20 pages, with very clear instructions also for low resource settings, but also for high resource settings. But it's easy to tailor those guidelines also to your local needs. And we try to include also their latest knowledge and best evidence on the management of hypertension. So to start off with, I thought best to start with a slide that's very well known when you look at aging. And that is to look at this graph, which includes over 1 million people's blood pressures plotted on the graph according to age. And as you can clearly see here, for both men and women, systolic blood pressure continues to decrease with increased aging, whereas for diastolic blood pressure, very well known, it really starts to drop around 60 years of age, or 55 roughly. And that also has been the consequence that when we are younger, this pulse pressure gap between systolic and diastolic blood pressure is quite a bit smaller than what we would typically see in older people. So in older populations, the increased systolic, lower diastolic blood pressure results in a high pulse pressure. And that is really reflected in this very old saying, which is so true, that a man or woman is as old as his arteries. And this really comes back to the physiology and pathophysiology and changes that occurs, especially in the large conduit vessels as we continue to age. In the Lancet Commission on Hypertension, we try to really incorporate this also with this focus on the life course approach in management of hypertension. That means to make sure that we really try and target treating it from young ages onwards to try and protect the vascular deterioration, because as soon as it starts to deteriorate at young ages, you have an increased loss of quality of life, of increases in disease development from early life onwards. So we all want this ideal life course reaching 80 plus years while still being healthy. But we typically see in most of the population that we have this average life course where we really at middle age and advanced ages already have organ damage, clinical disease development. And in some cases, and more, we see the situation of early vascular aging, where from early adulthood and middle age, we already see subclinical organ damage, development of clinical disease. And we really want to push this down. And that can only be done by early detection of raised blood pressure, by population-based strategies to ensure healthy lifestyle, prevention of disease development in the larger population. So just a bit more on early vascular aging, or in part of background in the situation of isolated systolic hypertension, is when we look at early vascular aging, it's something, it's known to be shaped by similar factors that are related to hypertension and a long life, and that is genetic programming, also epigenetic influences, in other words, gene-environment interaction, early life programming. When we look at adult lifestyle, smoking, major factor that we know one of the main causes of death still in the world, alcohol, nutrition, physical activity, and societal factors. And this all relates back to the health and of the structure of the wall of an artery. Here you can see also the different layers of the artery. And within each of these layers, we see embedded the elastic membranes, internal elastic membrane, external elastic membrane, elastic fibers. So we can see that all of these are embedded in the wall. And as we get older, or as there are changes due to the environmental interactions and other impacts, we see deterioration of these elastic membranes and an increased development of collagen in the arterial wall. And that is when we have this loss of arterial elasticity as we age, but also in some young individuals, we already know that. This is in research terms, arterial stiffness is often measured with pulse wave velocity. And mainly, therefore, as I said before, it's mainly the large aortic vessels that is impacted most, because the muscular arteries are not as elastic. It's the changes in the elasticity of the aorta that has a major impact on cardiovascular outcome. So why is this really important in this context? It's because arterial stiffness predicts cardiovascular events and or cause mortality, and it's done independent of blood pressure. So even if you don't look at blood pressure and only look at large artery stiffness, it's a strong predictor of cardiovascular outcome, but it is independently through the development of isolated systolic hypertension. As I show you here on this slide, which actually explains it pretty well, is if a person has elastic arteries during systole, you'd see the increase in capacitance, expansion here of the aorta during systole. So this is a drop in systolic blood pressure and pulse pressure. And with diastole, you see an increase in diastolic flow. Alternatively, if a person has stiff arteries, this is not the case, and the blood is propelled straight with an increase in pulse wave velocity going forward. And you see there's an increase in systolic and pulse pressure. There's no elasticity for the blood to be part of the expansion. And you see during diastole a lower diastolic flow. And that is what we see typically, as I've shown before in this graph, which we often see with increased age, is when you have this increase in systolic pressure, pulse pressure, and a lower diastolic flow. In terms of arterial stiffness, and that's measured by the gold standard measure of pulse wave velocity, in normal healthy individuals, you see this trajectory of increased arterial stiffness with increased age, and this is in a normal population. So this is something that does occur. This elastic degeneration with age is something that normally occur. But if you look at arterial stiffness in terms of aging, but also according to hypertension or blood pressure classification categories, you see that with optimal blood pressure, the blue bars, as age increases, your stiffness will increase. But when you look at, for example, grade 2 hypertension, it's the same, but you see a much greater increase in pulse wave velocity. So it's also dependent on your stages of hypertension. Right, so what does this have to do with isolated systolic hypertension in the bigger picture? And I will focus now on the 2020 ISH guidelines, and what we've put there is basically the definition where we say isolated systolic hypertension is defined as an elevated systolic blood pressure of 140 millimeters of mercury or higher and a low diastolic blood pressure. And this is common in young and in elderly people. Interestingly, we will get to the different profiles. In young individuals, which includes children, adolescents, and young adults, isolated systolic hypertension is the most common form of essential hypertension. However, it is also particularly common in the elderly, in whom it reflects stiffening of the large arteries with an increase in pulse pressure, the difference between systolic and diastolic blood pressure, as I've just explained. And then we will discuss a bit about the different two groups of young and the elderly, where we see this most commonly occurring. Also here in the European guidelines, I've extracted this from their guidelines. It's also included in a table where you see clearly the classification of office blood pressure and the definition. So yes, it's the same classification as in the International Society of Hypertension guidelines of 140 and 90, lower than 90, which is of course different from grade 1 hypertension. Also, what one can do, and this is taken from another paper focusing on isolated systolic hypertension, is you can also grade it for grade 1, 2, and 3 isolated systolic hypertension, which in fact is the same categories as we see for generally for hypertension, 140, 116 greater than 180, but in all instances, diastolic blood pressure remains low. So let's focus a bit on the young cohort. Young individuals, young patients, where we often see, when we see hypertension, it is often isolated systolic hypertension. So it says, particularly in young men, this isolated grade 1 systolic hypertension occurs. And what's interesting is those individuals often have a normal central blood pressure. So this is where I've shown the expansion of the aorta. It is still elastic in these young men, but they do see, due to excessive peripheral systolic pressure, that they are categorized as having isolated systolic hypertension. And that bears the question whether this is really something that one should treat, whether this is is it benign or not. And so it's unclear. And a study that was done in Chicago found that young men with isolated systolic hypertension had a cardiovascular risk that's similar to high normal blood pressure. So not that high risk, but it was often associated with smoking, which makes a lot of sense, which will result in increased peripheral arterial stiffness. And therefore, on the basis of what they've found there and other current evidence, it's mostly important to really give recommendations for lifestyle modification in young adults, particularly if they're smoking, to stop smoking. That they should do anyway. We know it's becoming quite a bit of a problem in young populations still. Even with newer formats of smoking, they are all detrimental, and whether they should receive drug treatment is still unclear. And therefore, as is often the case for isolated systolic hypertension, longer-term follow-up and individual aspects of the person's health should really be taken into account when deciding on what sort of treatment is ideal. But so if they're young and healthy, they should stop smoking, not specifically start with drug treatment, but checking follow-up. And if the risk seems high, I'd suggest rather start with treatment early to avoid early vascular aging, as we have discussed before. In terms of the elderly, I've spoken a lot of that in terms of the introductory slides. But what's important is that a lot of landmark clinical trials, as you may all be aware, have been done on the treatment of isolated systolic hypertension. Most of them were done in the 90s. SHEP trials, China trials in 97, 98. And then most recently, 2008 was the HIVET trial, including thousands of patients, mostly older than 60 years of age, whereas the HIVET trial was done in older than 80 years patients. And all of these trials saw dramatic major findings, reductions of stroke, 36%, for example, reduction in stroke, 42%, 38%, 30%, even in people aged 80 years and older. That is quite prominent findings. This is just summarized in this slide, as you can see. And the main treatment that was given was thiazide-like diuretics, chlorthalidone, and in this case, nintedanib, and then indapamide was in the last HIVET trial, resulting in a 30% reduction in stroke. If we just focus on the HIVET trial as the most recent one, which was published in 2008, you can clearly see they included 3,800 participants older than 80 years, and they had a high systolic, 160 or higher, and the diastolic was actually a bit higher than usually, less than 110. And so they gave them indapamide, and then add-on therapy was perindopril. What's interesting to see here is that systolic did lower substantially in the active group compared to placebo. Diastolic did decrease, but not too low, so that one would expect side effects such as dizziness, etc., or falls, although they are older than 80. But that is good. And the major drop in systolic blood pressure is clearly the driver for the reduction in strokes in this population. But the good news is they are highly effective medication, and therefore antihypertensive agents that are really recommended for systolic hypertension is thiazide-like diuretics and calcium channel blockers. What is important, it is not thiazides that are recommended. It's not hydrochlorothiazide, but thiazide-like indapamide and chlorthalidone are much more impactful in terms of lowering of blood pressure in this population. As secondary drugs recommended are ACE inhibitors and angiotensin receptor blockers. Compared to CCBs and thiazide-like diuretics, ACEs and ARBs have distinctly less efficacy in patients with isolated systolic hypertension. Quite interestingly, because they are often the drugs of choice, but not for the specific patient group, and it's potentially due to the pathophysiological pathways that are targeted with thiazide-like diuretics and calcium channel blockers. So the choices between different agents should also, importantly in this usually elderly population, be focused on the patient's comorbidities, tolerability, and clinical response, and therefore general management strategies should be decided on an individual basis with a primary aim of optimal blood pressure control. But minimizing adverse effects. We all know how sensitive and difficult this population group is to treat often. But to avoid beta blockers, seemingly have little, if any, efficacy in the management of hypertension. In the ISH guidelines, the target for treatment in patients older than 65 years are indicated as less than 140/90 if tolerated. But again, as I've mentioned before, always consider individual blood pressure target in the context of their frailty and their independence and likely tolerability of treatment. So, as some last comment, it's also good to know that a white coat hypertension, we know that is when you have higher blood pressure in the clinic with a doctor, but lower blood pressure at home, have shown to be have a greater cardiovascular risk in patients with isolated systolic hypertension and also in the elderly. It's often the same cohort. And it doesn't appear to be clinically innocent. So yes, it's something to keep in mind when you are treating older patients. They often have white coat hypertension. And also there is evidence indicating that isolated systolic hypertension characterized by increased aortic stiffness is associated with a limited response to renal denervation and baroreceptor stimulation. So that is potentially because renal denervation and baroreceptor stimulation is treatments, specialized treatments focusing on a sympathetic nervous system activity, whereas aortic stiffness is another pathophysiological pathway to increase blood pressure, and therefore it's not really surprising that those interventions are not as successful in treating isolated systolic hypertension. Right, so to end off, my take-home message is really that isolated systolic hypertension is highly prevalent in the elderly and a major cause of death and disabilities in the youth. It is also a common form of hypertension. Individualized treatment may be required using evidence-based therapies, starting off with calcium channel blockers and thiazide-like diuretics such as indapamide and chlorthalidone. And optimal systolic blood pressure treatment is unclear actually, but overall the target is of less than 140 millimeters of mercury seems the most reasonable. Thank you very much.
Thank you, Professor Alta, for an extensive discussion on the for this on isolated hypertension. Many new things to learn, and especially your endnotes about white coat hypertension. We are, as clinicians, many a times very dismissive of white coat hypertension. So, that message was, I think, very, very good. So while we were talking about isolated hypertension, we were joined by our chair for today, Professor Zahid Yassin Hashmi, who I think there were some connectivity issues. He graduated from King Edward Medical College in 1979 and has served as a professor of medicine and principal of Punjab Medical College, Faisalabad. And presently, he is chairman of Liver Trust and director of Liver Center, Faisalabad. Welcome, sir. We would now be moving on to the to our poll. And while this is running, I would request the participants to please prepare these questions, and then we would be taking comments from our panelists, Professor Bilal Muhyiddin Saab and Professor Tariq Wasim Saab, and obviously our chair, Professor Zahid Hashmi. The post poll questions, please. The participants are requested to kindly attempt these.
Alta, you'll be happy to know that nearly about 200 people are hooked in at the moment. And
excellent.
yes, so it's quite a well attended meeting.
Fantastic.
Okay, we got that. Later at the end, we will have a comparative study also where we will then ask you to comment on them.
Okay. Good to see great participation, especially in light of the other meetings.
Now, while we are waiting for the comparatives to come up, I'll take on the discussion. And Alta, my first point for you to sort of highlight is that we have all for many years been taught about this aging, advancing, and arterial stiffness. But to date, we don't really have any clear-cut guidelines how to, sort of cut down on it, how to control on it. Yes, there is this bit of smoking part that is there. There is a bit of lipid profiling that is there. But is this purely a genetic, or is this something that can be prevented? What is your take?
Yes, thank you. I think it's a question. There are many people working in this space of arterial stiffness, but clinically the meaning is really difficult to really pinpoint and say, how can we treat it? How can we manage it early onwards? At this stage, it's mostly the same components that really affect high blood pressure are the ones that's also relevant in terms of increased arterial stiffness. And to date, there are not really clear medication that you can say if a patient have arterial stiffness to treat it specifically with something already known. So, but indeed, there are, as you've mentioned, smoking is definitely a factor, but other lifestyle, patients that are obese from young ages onwards or less physically active. So lifestyle, unfortunately, the things that are so difficult to change are also the aspects that really affect increased arterial stiffness from younger ages onwards. And ideally, if you can really get large populations in a country like Pakistan with millions of young adults growing up in an environment, you would really like to have that environment as healthy as possible, or promoting healthy lifestyles, as it can really have a major population influence in reducing blood pressure also as they get older.
One of the questions posted in the group is that Dr. Ghulam Murtaza has asked that because of this polypill business coming up and all of these things, that can we give a thiazide-like diuretic and a calcium channel blocker together and feel safe, or do we need to space them out?
I think it's these days we really need to be open for combination therapy. Both can be low dose. I think importantly, again, you have to look at the individual patient and his or her specific profile and comorbidities. But overall, rather go for 2 medications at low dose than for 1 at a higher dose, as it will really lower the side effects and the risk, and have definitely increased efficacy in lowering blood pressure. So I would absolutely go for combination.
So for you, the thing is that we go with combinations. And one question that has always been asked with a lot of these pill medications is the timing of the medications. Pre-breakfast, with breakfast, after breakfast, lunch times, dinner times. How do you advise your patients?
I think it's the most important aspect is to make sure it's long acting, so that it doesn't require often dosings over 24 hours. So long acting is important. And there has been this controversy about whether to give medication at night time, and that it holds much more benefit than giving it early in the morning. But I think the results were really questioned, and opposing results came across. I think most importantly to have long acting, and to make sure it lasts 24 hours and that it be taken on the same time of day at this stage is probably the best advice.
Another interesting question that has been asked by Dr. Noor is that, do you think there is a role of any steroids in cutting down in arterial stiffness, especially if you see that there is high markers over there?
Yes, it could be, specific steroids may have an impact, especially when used by younger adults. So certainly, there's been a lot of evidence, I think, in specific groups that it can be quite risky, and therefore important to actually focus on that when you have such young patients, to really make sure what they are using and other potential external factors that may increase their risk.
Now with this COVID business going on so aggressively and a lot of people having impacted, and they're receiving steroids and all of this, many times it has also been noticed that despite the fact that these steroids are coming in high dose, their pressures don't really rise. And later on, what we have also seen is that their initial pre-hypertensive, their pre-COVID days treatments at times need to be really cut down in their post-COVID period for at least 6 months to a year. And from there, we sort of, and as they regain their body mass, etc., then they start coming up. So what is your take with your experience over there?
I think overall, if we are undergoing such a strange time, there are so many interventions when you look at COVID. People's complete way of living has changed dramatically, where some being isolated, and going through traumatic experiences. So the larger impact of all of this collectively is something to take into consideration as well. And then, as you say, together with other treatments, it may also have an impact. I have to say, over here in Sydney, in Australia, the COVID impact has been so low, we can't really compare with other groups. We live in strict lockdown also at the moment, so it's very different. But nevertheless, the whole systemic impact of the isolation is quite substantial, and I think it will take years before we really get back to normal in treating patients with hypertension as we've done before. Also, in light of all the controversy that there was at some stage on whether patients with hypertension should continue their RAS inhibitors and whether that's safe to do so. But of course, the latest evidence say they should absolutely continue to use their RAS inhibitors.
A very old question has once again popped up by Dr. Nazish Yaqub over here, that is regarding the Korsakoff sounds, that some of these patients, especially with arterial stiffness, their fourth sounds sort of persists all the way down to either even to 0 or even to 2030. Can you sort of a bit shed some highlight on what mechanisms? Is it really just arterial stiffness causing these Korsakoff sounds to persist? And do these Korsakoff sounds persistence, then they have their own acoustic effect on the vessels. So does that make a difference? Has anyone done any work on that? Any idea?
Actually, I don't know. That's a good question. I would think that with the increased arterial stiffness, that may have an effect on that sounds, as explained also earlier in terms of the physiological changes. But how it would impact the Korsakoff sounds, I'm unsure. I haven't really read anything specifically to guide clinicians on how to interpret those changes.
One of our attendees over here, Mr. Hafiz, Dr. Hafiz Yasser, has asked a question slightly outside the current discussion. He's asking, what is the treatment of choice regarding isolated diastolic hypertension? What is your take on that? Isolated diastolic hypertension.
Yes, that is also a difficult condition to treat and not seen as often. I think usually it's not even, I think, specifically addressed in the ISH hypertension guidelines, but more so in others. And there's been, I think, also more reports seeing that in younger populations. And so far, I think just following the traditional hypertensive treatment protocols is just the way to go in terms of ACE, ARB, CCBs, and diuretics.
And once again, the old question regarding labeling a person as isolated systolic hypertension, is it the same, like how many readings must be done, how frequently they be done, and then we label them that, look, this is what you have?
Yes, that's a good question. I'm actually doing quite a bit of work on that at the moment. And that is really that we should all realize how variable blood pressure is. It really changes from beat to beat. And if you don't measure it properly in the clinic, you will find it even more difficult to really make a diagnosis. And that's why, the traditional way of measuring blood pressure in the clinic, having 3 measurements, making sure the patient sits comfortably, and using the mean of the second and the third one, it's something that a lot of people simply don't do. And if we don't do that, we will not reduce the variability of blood pressure. So if we do that, and at least on 2 or 3 clinic visits, I think based on that, the diagnosis should be made as for traditional diagnosis of hypertension.
Dr. Noor has asked another question from you, and that is especially regarding the young ladies. And that is regarding the fact that do the contraceptive pills or these injections, etc., have an effect on arterial stiffness and cause anything over there? What is your take?
Yes, we've done a study on that actually, and oral contraceptives seem to have an effect on aldosterone, which is quite interesting. In young healthy cohort, we've looked at that, and I think when you see some strange changes in blood pressure with a young female patient, that sometimes it's necessary to look at the RAS inhibitor or the renin-angiotensin system, and particularly increased aldosterone seem that it may be an issue. But we'll have, there's not so much done on it, but there could be an influence on aldosterone levels that we have seen very clearly.
These days, there are a lot of hue and cry about the benefits of coenzyme Q10. Talha Munir basically asks that, what is your take with arterial stiffness? Is there a role, or just, there's a lot of things floating about?
Yes, I think there are many like Q10, coenzyme Q10, many flavonoids, and many other sort of potential interventions are being looked at, but we're looking for robust, broad-based evidence from several centers to really focus on that. And there may be a case that it can be beneficial, but I think for now, we're not there yet.
You're not there, yeah. And you did very well pointed out that, the calcium channel blockers and the thiazide type diuretics are the first line to go for. But at what stage would you say that I need to consider, or in which patient you may consider, rather than going for a calcium channel blocker and an ACE or an ARB, and or at what stage would you like to add on before this, that you would like to go to a full dosage of calcium channel blocker, or you'd like to go to a triple regime very quickly?
I think for starting off with treatment, starting with low dose thiazide-like and calcium channel blocker is the best way to go, low dose, and then reevaluating at least after a month. And when blood pressure is not yet controlled and the patient doesn't have any side effects, to increase the dose of those same medications. And as a month later, if it's still not improved, only then I would add a ACE or an ARB. As third line therapy, or if you can have triple combination drug, great, to increase adherence, that would be recommended. But usually I would start low dose and see if it's not sufficient to really reach target blood pressures.
So when we were talking about the arterial stiffness, it has been asked again that it was basically all the things which actually sort of predispose us towards atherosclerosis, and that is what needs to be cut down. So basically, what kind of an exercise can we recommend? Which form of an exercise? Is there any lines over there? Do we have any idea?
Yes, there's actually quite a lot of research going on, and I'm surprised to find that even if you do resistance training, with weights, that has a very good impact, but also aerobic exercise. So all these different forms of exercise are beneficial. I think the most important message we need to get across is to stop the sedentary lifestyle of only sitting in front of the webinar screens like we are all doing now, and to really make time for moving. And as I said, there are even studies showing that this very high intensity training, the short-term interval training, actually also have significant benefits. So I think all these different ranges, resistance exercise, aerobic exercise, high intensity training, all seem to be beneficial.
I think our IT poll is ready with a comparative study analysis, the questions. So IT, can you please show us? And Alta, with each question, we need your comments.
Thank you, Professor Alta. I think you have stimulated the minds of our participants. And here are the results of the poll. The first question about the isolated systolic hypertension.
Right, thank you. Yes, it's good to see that the correct answer has improved quite substantially from pre and post the presentation. So indeed, yes, so systolic blood pressure is the definition in general is the same for all different global hypertension organizations of greater than 140 and less than 90 millimeters of mercury.
Right. The second question was about the isolated hypertension is a condition that occurs in mostly which group?
Yes, so that's good to see that the correct answer is A and B. So the most got that one right. But I have understanding that many people selected older people pre-test, because that's where we see most, by far in numbers, the most patients with a condition of isolated systolic hypertension. But as I pointed out, when we see a high blood pressure in young people, it is often due to isolated systolic blood pressure as well. And therefore, it's good to be aware of that and to keep an eye out for that. So indeed, the answer is A and B.
Right. So we should not be dismissive of because of the age of somebody, that they cannot have this condition.
That's right.
Right. So the third question was about the underlying physiological underpinning of isolated systolic hypertension. And the correct answer, I believe, has increased from 53 to 72%.
That's correct. Very good to see that. And as I pointed also out at some of the last slides, that interventions like sympathetic or renal denervation, which addresses the sympathetic activation, isn't that successful in patients with isolated systolic hypertension. And therefore, indeed, the underpinning, as I've explained earlier in the presentation, is central arterial stiffness.
Right. And that brings us to the fourth question about, what should the patient with isolated systolic hypertension should ideally be treated with?
Yes, excellent. Most also had that one correct pre-test, but as I've shown clearly, calcium channel blockers and thiazide-like diuretics are prominently the first choice for treatment, and not so much ACE inhibitors and ARBs, which is often the go-to medication that we use for patients with hypertension in general. But in this case, clearly more effective to lower blood pressure with CCBs and thiazide-like diuretics. So great response.
Over here, one question that always comes up with this question is that if you have got a blood pressure of, let's say, you're 60 years of age and you have got a pressure of 150 by 85. So as per the definition, yes, you are isolated systolic hypertensive. But then there's that old philosophy that, so much pressures and plus age and it's not too bad. And then at 150 systolic, you just have shot out. So basically what I'm trying to hit is the people who still believe that lifestyle modifications. And where would you say, as far as diagnostic labeling is concerned, after 140, it is labeled. But at what stage would you say that you really, really need to start the treatment? 140 plus, you need to start the treatment, or 150 plus, you need to start the treatment?
I would say to start at 140 plus. Yeah. I think there's been a huge problem with doctors over the world, everywhere that's the case, to be too careful in prescribing medication for hypertension. And that's why we have such a large number of people that are not effectively treated. I often think we should go in higher risk people to go for lifestyle modification plus treatment. You know, I think when it's 145 or something like that, you should look at making sure of the diagnosis because of the variability of blood pressure, making sure they come for a second visit and that blood pressure is well taken correctly at both cases. And if it remains high, it should be treated. Otherwise, they just slip through the cracks, and next thing you know, their blood pressure is much higher and they suffer a stroke. So we should be more aggressive in general, I think.
Regarding this denervation bit, we don't have that done over here very frequently. What is it? How is it in Australia, one? And secondly, is denervation only limited to renal arteries, or any other place have they tried anything else also?
Renal denervation is in my opinion, it's invasive therapy that's not for broad scale populations, you know. So for me, with my personal interest also being in low middle income countries to reduce blood pressure there, that is really the last option for treating hypertension and in severely resistant patients. So it's mostly focused on the denervation of the renal arteries. At this stage, to my knowledge, there's not another area where it's really targeted, and it is successful. The latest trials that tested this, the Simplicity 3 trials, showed it really reduces blood pressure substantially, but only in those with a real resistant hypertension. But as I said, it's not an option in many places in the world.
I think, Dr. Sidra, it's time to start moving to the second presentation now. Yes. And Professor Alta, please stay with us throughout.
Sure.
Thank you, Professor Alta, for this stimulating discussion. I think we have all gained, and we would our practices will benefit, our patients will benefit from today's session. And before we move on to the next session, I would like to request Professor Zahid if he would like to have share his comments on our first talk. So kindly unmute, please.
Assalamu alaikum, Sidra. Hope I am audible.
Perfect.
Yes, sir, you are.
Lovely.
Perfectly audible.
Lovely. Thank you very much, and my apologies for joining you a bit late, as you rightly pointed out, due to issues of connectivity. I'm so grateful to Society of Internal Medicine for honoring me to chair this wonderful and very useful session. And I'm so pleased to see Bilal after a very long time. I think Professor Bilal, I'm seeing you after your fellowship exam, so it must have been quite a few decades. I think there was a time about half a century back when we were students at King Edward Medical College that we were taught that systolic hypertension is an absolutely physiological thing and it is not to be treated. And it is over a period of time that it has been evolved as not just as harmful as the usual systolic, diastolic hypertension is, in fact, being more important predictor of cardiovascular morbidity and mortality. And I feel so pleased to listen to Professor Alta for such a comprehensive and wonderful presentation. She has practically covered every aspect of isolated systolic hypertension. If I had the opportunity to ask her a question, I would have asked about the so-called secondary causes of isolated systolic hypertension, because she did cover de novo isolated systolic hypertension, but a couple of comments about the secondary causes of isolated systolic hypertension. I think she has rightly and very comprehensively talked about not just the pathophysiology and the need of controlling systolic hypertension in the elderly individuals, where this is the most prevalent form of hypertension. She has talked about the pharmacological agent. Just to repeat what has already been said, that thiazide diuretics and or thiazide-like diuretics and calcium channel blockers of dihydropyridine group being the mainstay, and the next in line would be ACE inhibitors and ARBs. However, there could be compelling indications to begin with ACE inhibitors or ARBs like they are elsewhere in our clinical practice, like post-MI, chronic kidney disease, etc., etc. She did talk about the combination therapy as well, and she has covered most of the other aspects. And I think what I have learned today is a group of younger individuals presenting for the first time with isolated systolic hypertension. She very rightly pointed out that when it comes to the treatment goal, it has to be individualized, particularly the very old individuals. I think individuals who are 80, 85 plus, there we have to be very cautious. And like we have always been saying and learning, that start low and go slow should be the policy. And I thank you once again, Dr. Sidra, and thank you, Dr. Bilal, and in particular, Professor Alta, for honoring us by her presence and giving such a comprehensive talk on this important topic of isolated systolic hypertension. Thank you very much.
Thank you, sir.
But Professor Alta, would you like to talk about the secondary features that Professor Zahid has asked you about? Would you like to comment on that?
Yes, if there's still time before the next presentation.
Yeah, we can take that one up. It's just one question and then we'll move forward.
Sure, I'm happy to discuss that. So there are, of course, secondary causes of systolic hypertension, and that's often occurring in patients with type 1 diabetes or in those with osteoporosis, and we have vascular calcification. So again, that vascular calcification will result in increase in stiffness. Or in patients with chronic kidney disease, you see accelerated atherosclerosis. Peripheral artery disease is another comorbidity where it's often a part of a secondary cause of systolic hypertension. So there are some of these situations where we need to be on the lookout for it. It's patients with CKD type 1 or actually type 2 diabetes as well, peripheral artery disease.
Great, second talk.
Thank you, Professor Alta. I think we should be moving on to the second talk now. Our next speaker for today is Professor Azad Ahmed Saab. He is the former head of nephrology in Federal Sheikh Zayed Postgraduate Medical Institute, National of Kidney Diseases, Lahore, and currently working as consultant nephrologist at several leading hospitals in Lahore. He graduated from King Edward Medical College in 1980 with several gold medals to his name, including a gold medal in surgery, a silver medal in surgery, and a gold medal in MBBS for securing the first position. And he is FCPS Medicine and FCPS Nephrology with the honor of being the first fellow of nephrology in Pakistan. And he also secured gold medal in nephrology for this. He has served for more than 2 decades at Sheikh Zayed PGMI and retired as professor and head of nephrology. And he has contributed significantly to nephrology being known and recognized in the country as a specialty. He has several national, international publications and presentations to his name in clinical meetings and conferences, and has been invited as speaker in many national and international conferences. Today, we are honored by his presence, and he will be talking about the renal aspects of secondary hypertension. Professor Azaz Mansab, please. Yes, sir.
Thank you very much, Dr. Sidra, for a very generous introduction. It was a very nice talk by Dr. Professor Alta, and I thoroughly enjoyed it. The task that I have been assigned to is to talk about the secondary hypertension. And this is a huge topic, and I will just try to, limit.
So now may I request you to kindly take a break and we go for the poll, the questions first. IT department.
Please run the poll. Right, this is the first question. So we would be having a comparison at the end. The participants are requested to kindly enter their responses so we can move on. Right, I think this was the last question. Professor Azaz Mansab, please.
Coming back to my presentation, secondary hypertension, a very vast subject. If we look at hypertension as such, the National Health and Nutritional Examination Survey data told us that about 30% of the people in the United States are hypertensive. The Framingham data says that the middle age with no hypertension have a 90% residual risk of becoming hypertensive. And those who are obese, more than 30% will develop hypertension. Now, when we talk about chronic kidney disease, in CKD stage 3, more than 60% of the patients, and in CKD stage 4 and 5, more than 80% have hypertension. And the sad thing is that majority of these patients, 70% or more, are uncontrolled as far as the guidelines concerned. So that's a huge burden, particularly in chronic kidney disease. There's hardly any patient you find in stage 4 or 5 who's not hypertensive. And this hypertension is so difficult to control that at least these patients require a minimum of 3 drugs to control their blood pressure. Now, coming to secondary hypertension, basically there are a lot of causes of secondary hypertension: high aldosterone states and hypothyroidism, hyperthyroidism, hyperparathyroidism because of increased calcium and increased cytosolic calcium, which causes vasoconstriction, and the blood vessel walls, they get the way Dr. Schultz has described the role of the blood vessel, Cushing syndrome, pheochromocytoma, congenital coarctation of aorta, certain genetic syndromes in the kidney, and then few drugs like erythropoietin and non-steroidals, which they take away the vasodilatory prostaglandins and cause hypertension and unopposed vasoconstriction, particularly in the renal bed. And then the oral contraceptives have been discussed. Calcineurin inhibitors, which are used widely in the renal population in transplant patients, and obstructive sleep apnea being increasingly recognized as a cause of hypertension. So majority of these things are not as common as the renal hypertension. So if I ever come across a young patient who is in his 20s or 30s and has hypertension, the bell should ring in the brain that it could be a renal hypertension. And we see a lot of patients who have been treated for hypertension with a family history sometimes. There's essential hypertension. Nobody looks at the renal aspects. Only last year came across a woman with a blood pressure of 200 by something, who has had 3 pregnancies, 3 cesarean sections, and she had uncontrolled blood pressure during all her pregnancies. And the last born is about 5 years old, and we looked at her for uncontrolled hypertension and just found that she had no pulses palpable in the lower limbs and very feeble femoral arteries. So it was a case of coarctation of aorta who had never been diagnosed. And there was a wide disparity of blood pressure in the upper and lower limbs. Similarly, we see a lot of patients who are in their CKD stage 4 or 5, unfortunately, they have never been worked up for a renal cause. And my learning is that 90% of the blood pressure originates in the kidney, even if it is essential hypertension. It depends on how much nephrons you were born with. If you were born with less number of nephrons, you are likely to develop essential hypertension. But obviously, renal vascular disease and renal parenchymal disease, these are the two areas where we must always exclude some pathology that is treatable or potentially treatable, and then prevent the damage from going on. When we talk about renal parenchymal disease, it could be acute or it could be chronic. You can see acute nephritic patients. Only yesterday I received a postgraduate medical student who developed a sore throat, and then 2 weeks later he developed hypertension and oliguria and smoky urine. And he's come with a serum creatinine of 14 milligrams per deciliter and is on dialysis. Acute nephritis or nephritic syndromes can present like this, and hypertension could be a part of it. Chronic pyelonephritis, renal stones, chronically scarred kidneys are a very well-known cause of hypertension. And unless we look for it, we are just going to treat hypertension and nothing more than that. Chronic nephritis, various forms of chronic glomerulonephritis, certain disorders like amyloidosis, polyarteritis nodosa, so on. And then polycystic kidneys. These are some of the examples that acute and chronic glomerulonephritis, certain systemic diseases which can affect the kidney, and that kidney involvement can give rise to hypertension. So I cannot, go on saying that this is a very important aspect that we ignore most of the time, at least in our part of the country, part of the world. So how do we go about diagnosing? We have to do the baseline renal function test, GFR estimation. Sometimes in the elderly, a creatinine of 1.3 or 4 milligram may be considered insignificant, but if you do a GFR estimation for age, you may find that this patient is already in CKD stage 3 or 4. So serum creatinine is not a true indicator. Of course, electrolytes help us, hyperkalemia, hypokalemia, hyponatremia, and so on. They do help us in finding out what sort of disease we are. Urine analysis, urine protein quantification is very important. And then GN serology, viral markers, autoimmune workup, myeloma screen, vasculitis screen. And sometimes you have to do a renal biopsy to ascertain the cause of renal disease and hypertension. Ultrasound, IVUs, DTPA, DMSS scans, and CT scans. These are some of the basic tests that we require while working up a patient, young patient with hypertension. The other category which gives rise to renal hypertension, which gives rise to blood pressure, is renovascular hypertension. And renovascular hypertension, you suspect if a young patient, less than 20 years of age or more than 50 years of age, suddenly the hypertension comes up. Or if there is a renal size disparity, normally the left kidney is slightly bigger than the right kidney by about half to 1 centimeter. But in case the disparity in size is more than 1.5 centimeters, one should consider kidney renovascular hypertension as a cause of high blood pressure. Or if there is severe or refractory hypertension, patient is already on 3 drugs, not controlled, or there is papilledema or hemorrhages, then up to 32% patients have been found to have renovascular hypertension. Or if patient had a stable blood pressure on some medication, and now there's an acute rise over a stable baseline blood pressure. It could be an atheromatous plaque developing in a renal artery ostium. Or if a patient comes with flash pulmonary edema, non-cardiogenic type, or if there is an unexplained acute rise in serum creatinine after an ACE inhibitor or an angiotensin receptor blocker, it would mean that the patient has some form of renovascular hypertension. Or if you are doing a coronary angio, and while you are doing a coronary angio, you just happen to put some dye in the kidney as well. So it has been seen that up to 15% of routine coronary angios, while you are doing, and you just happen to look at the renal arteries, you find that up to 15% of them may have renal artery stenosis as well. Or if a patient has peripheral vascular disease, for example, dorsalis pedis artery is not palpable, there is a chance that this patient also has renovascular hypertension. So these are the kind of indicators which should prompt one to think about the secondary cause of hypertension, particularly renovascular cause. Now the next question is, how do kidneys cause hypertension? It is easy. Reduced number of nephrons because of CKD, so that less salt and fluid filtration, salt and volume overload resulting from increased cardiac output and increased peripheral resistance, sympathetic nervous system stimulation, RAS stimulation, or endothelial dysfunction. There are various types of endotheliums from 1 to 5, and then nitric oxide, and then an imbalance occurs. And the endothelium is a very active structure, and endothelial dysfunction is part and parcel of the renal disease. Not only renal disease, but also if you have patients with proteinuria and is diabetic, most likely this patient also has silent arterial disease elsewhere in the carotids or in the coronaries. So sometimes proteinuria is a window to the diagnosis of silent coronary artery disease because of the endothelial dysfunction and all the changes that are occurring in the blood vessels. Vascular wall changes, and Dr. Schulte has very nicely explained the role of internal elastic membrane and the external elastic membrane, how these become. And of course, all these factors, the sympathetic nervous system, the RAS stimulation, the peripheral resistance, the nitric oxide release, which is vasodilatory, and the increased endothelin 1, all these cause intimal fibrosis and shrinkage. And then, of course, the oxidative stress. So there are multiple mechanisms by which the kidneys cause hypertension. Volume overload, persistent volume expansion, typically not sufficient to produce edema, but there is relative volume expansion. Or patients' BNP levels are high, which are suggesting volume overload. Not necessarily from a cardiac dysfunction. Diuretics should be titrated until the blood pressure goal. So majority of these patients will require some form of diuretic. And if the GFR is not very low, then a thiazide or thiazide-like diuretic is effective. But if the GFR is low, then a loop diuretic is usually required. And in patients with GFR less than 30 mils, loop diuretics are required for better diuresis. Now, what is the link of this renal disease? Of course, it causes high blood pressure, but then both of these lead to cardiovascular risks. And the advanced trial has shown that if the GFR is less than 60 and there is albuminuria, then the cardiovascular risk is increased by threefold. And the Renal study also showed that a low GFR and albuminuria have profound cardiovascular risks. And for every 50% reduction in proteinuria, no matter how you achieve it, there is reduced cardiovascular risk by 18%. So these are very significant factors that how the kidney and renal hypertension is contributing towards worsening the cardiac risk and reducing the cardiac risk if proteinuria and GFR is improved. So there are effects on cardiovascular mortality. There are effects on the kidney itself if the blood pressure is not controlled, and the effects on the rate of progression of CKD with elevated blood pressure, and then the effect on the longevity or survival in hemodialysis patients. All these factors are affected if the blood pressure is not high. And what is the link of blood pressure with the fall in the GFR? If you have a mean arterial pressure of less than 91, then the rate of fall of GFR per year is about 3.9 ml per minute. But if the mean arterial pressure is between 91 and 106, the rate is higher, 4.4. And if the mean arterial pressure is more than 106, then you tend to lose about 7.6 ml GFR every year. So in about 5 years, 35 to 40% kidney function will be gone if the blood pressure is more than, mean arterial pressure is more than 106. And this accelerated hypertension leads to intimal hyperplasia, and this is a vicious cycle. Intimal hyperplasia then causes more hypertension. There could be thrombotic microangiopathy associated with it, particularly in conditions like malignant hypertension, nephrosclerosis, vascular sclerosis, and these lead to interstitial fibrosis in the glomeruli and cause damage. So hypertension acceleration can affect the kidneys in various ways. Now, what is the role of albuminuria? These Kaplan-Meier graphs, if you look at the survival in normoalbuminuric, it's a lot better. It is worse in the microalbuminuric patients, and it is much worse in patients who have macroalbuminuria. So if you reduce the albuminuria by, let's say, 50%, you improve the survival, because this albuminuria is directly linked with the cardiovascular mortality risk. And the RAIN study and the MDRD study have shown the benefits of reducing proteinuria. And 1 gram reduction in proteinuria per day, it stops the GFR from declining by about 0.9 to 1.3 ml per year. The Goldblatt hypertension, the role of renal artery stenosis. Unilateral renal artery stenosis leads to ischemia. Ischemia leads to high renin, high angiotensin, high aldosterone, vascular constriction, hemodynamic changes, and sodium retention. What does this contralateral kidney do? The contralateral kidney tries to, the renin gets suppressed and there is pressure natriuresis. So if there's unilateral renal artery stenosis, then things are quite different as compared to the two-clip Goldblatt hypertension. When both the renal arteries are stenosed, there is high renin-angiotensin system, high aldosterone, and then normal or low aldosterone, because the low sodium and water excretion, because both are affected, the contralateral kidney is not doing the natriuresis, leads to volume expansion. And this leads to high blood pressure, and this causes low or normal aldosterone. The renovascular hypertension is divided into two categories. One category is fibromuscular dysplasia, which is typically seen in young females. And the second is atherosclerosis, which is seen in middle age or elderly males more commonly. In fibromuscular dysplasia, the distal two-thirds of the renal arteries is involved. The proximal intrarenal branches may be involved. Females are generally younger. It is generally a non-progressive disease. And iliac, celiac, and hepatic vessels may also be involved. But the atherosclerotic type of renal artery stenosis is usually seen in the proximal one-third or at the orifice where it is originating from the aorta, and males relatively middle or old age. It's a progressive disease because this atherosclerosis is progressive generally, and extrarenal vessels may be involved as well. These are the typical angiograms that you see. This is fibromuscular dysplasia. You see this beaded appearance here, and this is a typical atherosclerotic type of lesion where the runoff is good, but there's a critical stenosis present here near the ostium. The other causes are again of renovascular disease are the atheroembolic disease, atheromatous renal artery stenosis, renal artery thrombosis, embolism, or infarction, or large vessel arthritis like polyarthritis nodosa or Takayasu's arthritis, or if there is a case of transplant rejection, or if there is renal artery dissection. This atheroembolic disease can also occur when the cardiologists are doing the interventionists are doing the interventions, because when your catheter goes in, you tend to shower emboli into the circulation and you get multiple cholesterol emboli syndrome, MCES. And this causes sometimes a glomerulonephritis-like picture and hypocomplementemia, and is a cause of acute kidney injury following coronary angiography. It's not just the contrast that damages the kidney, it is also the atheroemboli which go and settle in the kidney. The workup of renal artery stenosis, these tests that we used to do in the past, rapid sequence IVU, that you, instead of taking films at 5 minutes, you take a film at 1 minute after giving the contrast. And the kidney which has stenosis will not show you the dye. The one which is healthy will show you the dye. Of course, at 5 minutes, both the kidneys will show the dye. So you do a rapid sequence early, or you take a late film in which the dye is excreted from the normal side, but the stenotic side, the dye is still present. But a bit cumbersome. We used to request renal plasma renin activity and do the samples at various intervals of giving captopril, or do a renal vein sampling. These have virtually become obsolete because we have got now, with the advances in physics, we've got better tools. We've got duplex Doppler, and one can do a resistive index, which is calculated by 1 minus end diastolic velocity over maximum systolic velocity into 100, and an RI of 0.8 has significance, shows that there is, or if there is more than 50 to 60% stenosis, you can pick up on this duplex Doppler ultrasound. The sensitivity of this test is 0.88. That means it still misses out 12% cases. And the specificity of this is 0.9. That means it misses out only 10%. Or one can do a CT angiography, or a digital subtraction angiography, or MR angiography, or a renogram and captopril renography, that you give captopril baseline. You do a baseline study and then you give captopril, and then you do the scan again, and you see how much decrease in the uptake of isotope has taken place. Word of caution here, while you are doing MR or CT angio, then contrast can affect the kidney if the renal function is not normal, even if you're using a non-ionic contrast. The gadolinium used in MR is also nephrotoxic, and it can cause a new disease which has come up called nephrogenic systemic fibrosis, NSF, nephrogenic systemic fibrosis. So one has to be careful with gadolinium as well. This is a DTP renogram, isotope renogram. You can see typically the normal kidney has uptake up to here of the isotope, and then an excretory phase. This is the secretory phase. Uptake up till here, then the secretory phase, and then we have the excretory phase. But the side which has stenosis, or if you have given captopril and you've done a baseline study and then given captopril, then this uptake is reduced on the stenose side as compared to this one. The slope is a bit flat. That means the secretion is also slow. And then the excretion is also slow. So all the three components are here shifted to the right and delayed if there is a renal artery stenosis. So coming to the treatment of renovascular hypertension, if it is a unilateral disease, then ACE inhibitors or angiotensin receptor blockers and diuretics are the treatment of choice. But if there is bilateral renal artery stenosis, then it should be avoided. And of course, you treat the underlying disease. If it is due to polyarteritis nodosa or it is atherosclerosis, you treat. Or sometimes you have to do interventions and percutaneous transrenal artery angiography or angioplasty and stent placement is possible, or a renal denervation. As Dr. Schulte has already talked about, the simplicity catheter, and sometimes surgery. If the runoff of the blood vessel is good and for some reason you can't place a stent inside, then surgery may be considered. So the indications are not very clear cut as far as the stenting is concerned, and these indications are evolving actually. And the short duration of hypertension which is refractory to pharmacotherapy, or recurrent flash pulmonary edema, or ostial atherosclerotic disease, or heart failure or refractory hypertension, or renal artery stenosis more than 70%, or unexplained renal insufficiency, or a creatinine, which is less than 3 milligrams, because if it is already high, then there's no point in doing this, or a kidney size which is greater than 8 centimeters. A small kidney with a small vessel, there's no point in doing angioplasty and doing stenting because you won't gain anything. The CORAL trial and Astral trial, with the worthy speaker has talked about the success and the prolonged effects of denervation, and these stentings and plasties are not well known, and really you have to be very selective in picking up the patient for these procedures, because sometimes you may be doing more harm. Basically, the mechanism of renal denervation, there's decreased efferent sympathetic signaling to the kidneys and reducing the norepinephrine spillover and some natriuresis, and increasing the renal blood flow and lowering the plasma renin activity and decreasing the afferent signaling sympathetic activation. These are the things that you somehow touch upon when you are doing the denervation. But again, the trials have shown that sometimes again after some time the blood pressure goes up, and the data is not very impressive as far as the results of these, and of course it is expensive, and sometimes you can end up with damaging the vessel and causing more harm than actually benefiting the patient. The guidelines, if you look at the American guidelines which have come up over the years, the values of blood pressure more than 160/90, this is what JNC3 said in 1984. And now down the road, 130/80 in 2017, the American College of Cardiology and American Heart Association have come down because a lot of patients who were not treated at this stage ended up with strokes and MIs and renal insufficiency. So I think diseases like white coat hypertension and diseases like isolated systolic hypertension have to be more strictly treated. Of course, you have to individualize, you have to tailor the treatment according to each individual patient. But these guidelines have evolved for certain reason because the data has been. The goal for keeping in CKD, keeping the blood pressure is less than 130/80, particularly in patients, diabetic patients who are proteinuric. And the SPRINT trial documented that less than 120 decreased the mortality in non-diabetics at high cardiovascular risk. The MDRD also and the ASK trial suggested blood pressure go less than 130/80 will reduce mortality in patients with CKD. My last slide, the take-home message. Kidneys are the main key players in hypertension, even if it is essential hypertension. So don't forget your friend nephrologist while you are treating hypertension. It's not just the cardiologist or the internist. The nephrologist has to be taken on board. Hypertension occurs in large number of, because this is where the hypertension originates. It doesn't originate in the heart. It doesn't originate in the brain. It doesn't originate in the peripheral blood vessels. It originates in the kidney. Hypertension occurs in large number of CKD patients and causes its progression. The CKD patients have endothelial dysfunction and therefore they die from cardiovascular disease. In young hypertensive patients, renal disease must be ruled out. And proteinuria is a major risk factor for mortality. And lower the proteinuria, lower is the risk of dying from heart attacks and renal impairment. And hypertension in special situations requires expert management. Thank you very much. I hope I'm on time.
Thank you very much on time, sir. Now the post test, please.
We would IT department kindly play the post poll. Thank you, sir, for an elaborate discussion on the renal aspects of secondary hypertension. As you very rightly pointed out, it is often ignored and just keep on adding, clinicians keep on adding different medications rather than investigating the underlying cause. So I think this is a very important talk that has been shared today. So we would take a few minutes, and meanwhile, I think there are questions in the chat box. We would be presenting them to you once the poll is over. I would request the participants to kindly attempt the poll and also to put up their questions. If anybody would like to go live, please let me know. Right, and that is the last question, the last poll question. After that, we will be taking questions from the participants.
While we wait for the participants to start posting their questions, and I will start taking them on with both the honorable presenters. Professor Azman is a teacher of many. He's my teacher also, and many times while I was working, and I've asked him so many times to come and help us out in so many clinical scenarios, and he's always so very kind, and we've always been humbled by his kindness to the profession. Azad, there's this discussion which goes on, the lower the better. And at pulse pressure of 91, we are still losing 3.9%, as you pointed out. So if the pulse pressure is 120, we are still at 91 and we are losing out, what more to be done? We are already 120/80. How can we actually prevent the kidney decay? That is the question. Is there a way?
I think you perhaps can not prevent it, but you can just retard the progression. The rate of progression can be affected. Kidney disease, once the creatinine is slightly above normal, generally it is a progressive disease because the surviving nephrons, some nephrons are already sclerosed, and the surviving nephrons have to hyperfunction. And when they hyperfunction, they again go glomerulosclerosis, hyperfiltration injury. So that is why the kidney disease is usually progressive. Even if you don't see an increase in the serum creatinine, I mean, if you are 20 years old, your GFR is 120. And when you are 60 years old, your GFR is down to 60. No matter you have hypertension or you don't have hypertension, even if you are healthy, your GFR is going to decline by 10% in a decade. So there is an
only
aging
thing to
of
do is not to get old.
Not to get worried and keep your blood pressures in such a range that the rate of decline is minimized.
Another question that you pointed out was that about this protein loss that we have, and something which is not given enough importance, unfortunately. And then you have pointed out very kindly that, you know, if you get your protein down by 50%, that is going to make a big difference. One of the only things that we are normally able to do is that we can get the pressures controlled. Now, despite the pressure control, if you cannot get the protein down, what else can be done?
See, the proteinuria, somehow you ask for a dipstick or the routine urine, and there is no protein in the urine, so you tend to ignore it. But forgetting that microalbuminuria starts much earlier in hypertensive patients. With the onset of hypertension, they start to get microalbuminuria. And this you can only detect if you ask for a microalbumin test, and or you do the spot ratios of albumin and creatinine. Instead of assessing albuminuria used to be very cumbersome. You have to collect the 24-hour urine and all. But now you can do the ratios. You can do urine protein or albumin to creatinine per gram ratio. And if you're falling inside it, then it's good enough. Otherwise, you add an ACE inhibitor to, supposing you are treating isolated systolic hypertension with a diuretic and a calcium channel blocker, and you find that there is microalbuminuria, then you might as well add an ACE inhibitor or an ARB, or select a non-dihydropyridine calcium channel blocker, which has added benefit as compared to a dihydropyridine calcium channel blocker.
So my question is basically in reference to what more than medication we have, is there anything in lifestyle modification that we can do to reduce the protein?
There is a lot you can do in lifestyle modification, and that includes diet as well. So I think you have to cut down a little bit on the high protein intake, and particularly use protein of high biological value, but slightly less in quantity, because higher the protein consumption, higher will be the proteinuria. The second thing is weight control, because weight is also linked with the proteinuria. And you know very well that obesity is linked with the focal segmental glomerulosclerosis, a cause of kidney damage. FSGS is well known in obese patients. So I think weight control is again very important. Ideal body weight person should achieve. The salt intake should be reduced, and the exercise is important. All these factors, which COVID has literally changed everything in our lives.
Yeah. Another thing that we have pointed out is, since I am an interventional cardiologist, and one of the fears always is that the cholesterol and the embolic showers that are known to be produced. You do whatever you can as far as carrying your catheters is concerned, as far as manipulation is concerned, so that you don't do it. Since you also do all of these things with the kidneys area, what more can a person do to prevent? But thereby saying that, what is the role of high dose statins to be administered well before we can do this procedure? What is your take on these things?
I think particularly patients who have evidence of vascular disease, whether it is in the carotids or it is in the coronaries or it is in the renal arteries, I think statins are the mainstay, more than the antiplatelet drugs, I would say, and higher doses of statins if tolerated, because somehow our genetically maybe or what population is not very comfortable with doses like 80 milligrams of atenolol or 40 milligrams of rosuvastatin, and they get a lot of aches and pains, and then they use CoQ enzyme supplements with the statins. So they have a role, but atheromatous plaques in the renal arteries as such have not been studied so well. And I'm not aware of any study in which they have particularly looked at improvement in the renal blood flows and other things with the use of high dose of statins. But in general, one can perhaps apply this, because vasculature is more or less the same everywhere, except cerebral, where you have dichotomously branching vessels and end arteries is different as compared to the coronary and renal circulation.
The unfortunate reality with a lot of cardiologists is that they do an angiogram, coronaries, they see a stenosis, and they want to put a stent inside. And when they come in and have a look at the renal arteries, the same is the case over there. It's a stenosis, and you have very kindly pointed out the things which actually should be looked at before that. But if you come across bilateral renal artery stenosis, should this be a standard knee-jerk response, stent it?
Not necessarily.
Bilateral knee, should you stent it?
Depends what is the runoff, what is the condition of the kidney, how much is the glomerulosclerosis, how much the kidney size, all these things matter quite a lot. Of course, drug-eluting stents can help in renal stents. Similar, you can put not the conventional, the drug-eluting stents can help in the renal vasculature, but then you have to have those indications for putting in stents, which I have mentioned. That you have to be selective. Previously, people used to find a renal artery, 70% stenosis, put in a stent. So what benefit actually you get if glomerulosclerosis has already taken place? There is not much role in that. So you have to be selective, you have to individualize. There are certain patients where we have had stentings done from your institute, and from our cardiologist at Sheikh Zayed. I mean, a woman came with AKI, complete shutdown after taking ACE inhibitors, and she had bilateral disease, and the better kidney was then stented, and she improved. to the extent that she was off dialysis, but she never had baseline normal kidneys, because these are slowly progressive lesions in the renal vasculature, and as the blood flow to the kidney reduces, so does the nephron function. So in the end, if you are not going to get any benefit in terms of renal function improvement, there's no point. But on the other hand, if it is a case of resistant hypertension, and you are able to, by stenting, able to reduce the number of drugs, of course, you won't be able to stop the antihypertensive therapy, but you may be able to manage it better by moving from 5 drugs to 4 drugs, something like that.
Now, so
And
we
this
have
is what the denervation processes, the sympathetic denervation has also shown that initially there was a benefit, but then in the long run, again, there was problem.
We have a lot of questions regarding the drugs and dosage, but before I take on, I think you'll be answering all of these questions in the comparative analysis. So IT is ready, and sir, we would like to have your comments and answers as we go on with it.
This was the first question, and we have.
What is your take, sir, over here?
Best investigation for renovascular disorders.
Yes, I think people have, majority people have in the pre-test voted for duplex ultrasound of renal arteries. Of course, it is very useful. And in the post-test also, the numbers have gone higher from 53 to 78. But the CT angiogram has actually gone down. And we were considering this as, of course, it is debatable to some extent, but CT angiogram is perhaps the gold standard for finding out because sometimes the duplex Doppler can be deceptive. But CT angio is almost like a gold standard. And if you do a CT angio, then you can not only see the degree of lesion, and you can also perhaps treat in one go.
Probably over here, your trick part was that you had a normal creatinine, and if your creatinine was very high, then probably.
Then if your creatinine is high, then obviously you can't do CTs that comfortably, and you are limited to then duplex Doppler. A conventional non-Doppler renal ultrasound won't tell you anything. So I think it has no role. Out of these 3 options, if the serum creatinine is normal, it's better to go for a CT angio, because this is a 30-year-old woman and very likely to have fibromuscular dysplasia. And fibromuscular dysplasia you can only pick up on CT, not on duplex Doppler, because that typical beaded appearance will come on the CT angio, and the results of stenting are good.
Right.
Perfect. Next question.
So moving on to the next question. Right. So we were asking about the characteristics of this patient's renovascular disease.
Right.
Okay.
So
it is the same percentage, 52% pre-test and 52% post-test.
Yes, the correct answer is this, that renal artery stenting may improve blood pressure, but it is less likely to reduce antihypertensive, because patients already is on quadruple therapy, and the creatinine is 1.5, and blood pressure is marginally controlled with quadruple therapy. So you cannot perhaps reduce it, but you can maybe control it a little better, and this might be the correct answer. So renal artery revascularization would lead to withdrawal of antihypertensive, very unlikely, that because 4 drugs our patient is already on. And withdrawal of losartan would improve his kidney function, again, very, very unlikely, because it is a unilateral stenosis.
Right. The third question.
Third is,
yes.
Yes, I think this it has improved significantly. calcium channel blockers have gone down, and the correct answer is stop the ACE inhibitor. And why? Because the creatinine, the rise in serum creatinine is substantial. The rule is that if you have a 30% increase in the serum creatinine from baseline, for example, you started the ACE inhibitor at a serum creatinine of 1, and now it becomes 1.4 after starting the ACE inhibitor. That means there is a 40% increase in the serum creatinine. So in this case, ACE inhibitor should be stopped. So we started at 1.5 and now it is 2.4. So it's like 50%, 60% increase in the serum creatinine from baseline. So this
So
is
a lot of problem with this is happening is that people are now starting using a lot of combination tablets. So you basically say that since a combination tablet has been used, thus that you need to remodify the treatment. Would you like to add on that?
Yes, I think the combination depends what you are using. If you are using ACE inhibitor with a diuretic, you're likely to have more advanced, more enhanced effect, because the diuretics will increase the renin level. If you give a diuretic, the renin level will go up because of relative hypovolemia. And then the ACE inhibitor's effect will be more profound as compared to a patient who is not volume depleted. That is why you generally combine an ACE inhibitor with a diuretic in order to get the maximum out of the ACE inhibitor. So if you are using that, perhaps you can revisit. But if you are using a calcium channel blocker, then you can't tell what is going on. Obviously, the calcium channel blocker will not reduce the GFR or not increase the serum creatinine. The ACE inhibitor part of it will do it.
So you would say that in both of them, they both should be stopped, and you should then move away from the ACE-ARB and move towards a unilateral drug.
Yes.
And sir, if you move towards a diuretic plus a calcium channel blocker.
If the patient is proteinuric, then you give if you can manage, give a non-dihydropyridine calcium channel blocker rather than using nifedipine or amlodipine. I think using a diuretic along with the calcium channel blocker is not a bad idea. And you have preparations now available in the market where you have a diuretic and a calcium channel blocker. And these would be patients who cannot tolerate ACE inhibitors or ARBs.
Another question that many times comes up is the use of non-dihydropyridine and dihydropyridine in resistant hypertension together. Would you like to comment on that right now?
Yes, some people do it, but I would rather add another agent instead of giving 2 calcium channel blockers, because they tend to
sir, as a 5th drug. This is as a 4th or the 5th drug, not as the first 2 drugs.
I think then you need to better find out why this blood pressure is not being controlled, because there could be compliance issues, there could be some other things underlying that you are not looking at. So sometimes the salt intake is so high that the blood pressure doesn't get better, and we go on adding antihypertensive medication without knowing. Patient is taking a lot of cola drinks at the same time, a lot of salt injection. There was a case presented in the American Society of Hypertension meeting by the president of the American Society of Hypertension. And he said that a case was referred to me for uncontrolled hypertension workup. And I admitted him, and I measured his urine sodium, and it was high, and I kept him there, and I stopped his salt intake. And within weeks, he was back on single drug therapy from 4 drugs, just by cutting down the salt in his diet. So I think this is a very, very important and neglected aspect of hypertension management, that salt intake has to be reduced to at least below 2 grams.
So since you have touched on the salt part, what is the lowest sodium level you're comfortable with?
I think like 2
Serum
grams
sodium
a
level.
day. 2 grams a day.
And so, checking it level, would you consider to go as low as 130, or would you prefer to stay above 135?
No,
Stay between 135 and 140.
the serum sodium level is not a true indicator of the total body salt. You can have a low sodium with lot of sodium excess, low serum sodium with lot of sodium excess in your body, like patients with heart failure. So, so the serum sodium does not reflect the overall salt status at all.
I'm especially referring to this question because a lot of people are holding on to this advice because they say that the patients may go into hyponatremia, and that hyponatremia then becomes a reason. So that is the reference of this question.
I don't think it will happen if you have normally functioning kidneys. It will not happen. Because salt metabolism is always coupled with water metabolism. You cannot separate salt from water. If sodium goes up, most likely you have dehydration or you have water deficit. And if sodium goes down, it could be hypovolemic hyponatremia, or it could be hypervolemic hyponatremia.
Right,
Another question, number 4.
Last question. Yes, asked about the cause of secondary hypertension in this.
This is sad, you know. This is the pre-test. You see, it's clearly mentioned plasma aldosterone levels are low. In the stem, it is mentioned, and then people write primary hyperaldosteronism as a cause. It's not possible, because it's already mentioned that aldosterone level, so it can't be primary hyperaldosteronism. It has to be anything other than this. And it is Liddle syndrome. It's a genetic disorder where you have the ENaC, the epithelial sodium channels, you know, which are excreting a lot of potassium and retaining sodium. And there's a family history. It's a genetic disorder. And I mean, if in a young patient who comes with whatever isolated systolic hypertension, or comes with diastolic hypertension, and there is a family history of hypertension, you must consider, at least in your differentials, Liddle syndrome as a cause, and do the urinary potassium, and do the urinary, and do the serum bicarbonate, because it produces a picture like hyperaldosteronism, primary hyperaldosteronism. Just give me a minute to little bit expand on this. You see, if you are dealing with a case of a new patient with hypertension, you must always look at the electrolytes, particularly potassium, sodium, and bicarbonate. If you have alkalosis, then and you have hypokalemia, then you must rule out these 4 conditions. But in Bartter syndrome, you don't get hypertension. It behaves like furosemide. Just like the electrolyte disorders that you get with furosemide overdose, you get in Bartter syndrome. The Liddle syndrome, you have another syndrome called Gordon syndrome, in which there is hypertension, but then there is metabolic acidosis and hyperkalemia. And Gitelman syndrome, it's like thiazide diuretic. The primary hyperaldosteronism, you have increased levels of plasma aldosterone. And only, I think 3 months ago, I received a woman who had been discharged from medical ICU for treated as familial periodic paralysis, because she had quadriparesis and admitted to ICU, and where her potassium was found to be like 2.8, and given potassium supplements, and her improvement and her muscle strength came back, and she was referred for hypokalemia management. And she was also hypertensive. Looked at her bicarbonate, it was 28. And then I did the aldosterone levels were very high. And the aldo the aldosterone renin ratios were high also. So I asked for a CT scan of the adrenals, and they did an MRI, and they found an adenoma sitting there. So hypertension is not all that number game. You just don't start with giving antihypertensive. You have to see. You must see the electrolytes. You must see the bicarbonate. And if you have alkalosis and potassium and a low aldosterone, then you are perhaps a young person dealing with Liddle syndrome. So that's why I brought it up. Renal artery stenosis would not give rise to hypokalemia and alkalosis, less likely. And moreover, you may get some bruit or something. So low aldosterone levels rule out these possibilities. And if you do a urinary...
Can you remove the questions?
PSIM,
Right. So we have, during the discussion, we've almost answered all the questions from the participants. As we are running behind schedule, I would like a brief comment from Professor Azizur Rahman, who has just joined us shortly.
And after that, we can have a comment from Professor Alta and then with the chair.
We will have a closing and then the closing comments from Professor Zahid Hashmi. Sir, if I am audible, kindly, I think Professor Aziz is again having some...
Professor Azizur Rahman is actually in the car and is driving down, and Dr. Somya is also with us. If she can make any comments, anyone? Dr. Somya, would you like to add something? Is
okay,
she,
I think she's also traveling.
I think she's yeah, they're all traveling down at the moment. So I'll say that.
Right. Professor Alta, would you like to make your final remark, please?
Yes, thank you. Thank you very much. I think this is a great discussion, and also the previous presentation from Professor Aziaz, it just showed that there are so many aspects that we all need to sharpen up on. It's not always so simple to correctly treat hypertension, although I think in the majority of the population, there are standard treatments that's applicable to most, but there are clearly certain aspects to look out for secondary hypertension. And then, of course, also having the unique situation of isolated systolic hypertension, which I tried to highlight. I think one comment I just wanted to make to really end off and as a reminder is that, and I referred to that recently very briefly, is that we need to be very more aggressive in terms of managing hypertension. It's not benign. If it's greater than 140, it's not okay. It's not as if it's going to be better next time. It will likely be higher. And people are just kind of, you know, the patient doesn't show any symptoms and they have another problem, so you rather attend to that. Do not ignore it. You will do your patient a huge favor in the long term. Make sure that you keep track of it, that you measure blood pressure correctly and reliably, and that you treat it aggressively early onwards. That is a major problem, and we need all to work together and spread that message and really change the situation. Fortunately, antihypertensive medications are really overall available. It's not very expensive. There's lots of generics available, so it's not one of the expensive treatments out there. So hopefully it is possible to do so. So I think I'll stop there and thank everyone for this great panel and discussion.
Thank you. Thank you for joining us. It has indeed been a pleasure having you in our course. And before I hand over the mic to Professor Zahid Hashmi for the concluding remarks, I would like to request everyone to join in next week when we will be expanding on the secondary hypertension and talking about the non-renal aspects and the resistant and pseudo-resistant hypertension. Professor Zahid, please.
Assalamu alaikum once again. I think it was an absolute pleasure to be part of this quality session. We had two very scholarly presentations. I've already talked about I've already commented about the presentation of Professor Alta. Professor Azizur with whom I have the pleasure of being a class fellow, was spot on, and he gave a very scholarly presentation, and the discussion which we had subsequently was also absolutely wonderful. I have thoroughly personally enjoyed it, and I'm sure all the participants have also enjoyed it. And I would like to thank the Society of Internal Medicine once again for honoring me to chair such a wonderful session. Thank you. Thank you very much.
Thank you, sir. On that note, I would like to mention that today's activity would not have been possible without the support of ATCO Laboratories, represented today by Mr. Kashyap Vyas. And I would like to close this session by thanking our speakers, Professor Elta Shoot and Professor Azazman Ahmed Saab, our panelists, Professor Bilal Muhyiddin Saab, our chair for today, Professor Zahid Hashmi, and our panelist who could not, who had some connectivity issues. And we hope that the participants would be with us in the coming weeks till the concluding. And I thank you all for your attention and for your patience.
Thank you. Thank you very much.
Thank you all, and inshallah see
Thank
you
you.
next week.
Thank you all.
Thank you. Allah Hafiz.
And Professor Alta, you are welcome to attend with us if possible for you. It would be great to have you online.
Thank you very much.
Thank you. Take care. And once again, and I hope you have a lovely evening now.
Thank you.
Bye-bye.
Same to you all. Thank you very much.
Thank you.
Bye.
Thank you, Dr.
Bye-bye.
Sidra.